Time for part 3 of Maryam Kavousi's lecture, Data Collection and Accuracy.
So, welcome back to the third lecture of implementation of sex and gender in research design. At the end of the previous lecture, I asked you to think about whether big data is answer to everything. In the era where increasingly large and larger data sets are becoming available and publicly available, we are very, I have to say, tempted to look at various subgroup analyses, including looking for sex and gender differences in the data sets that are available. Because simply, we have the sample size, and there is a variable sex in each of the publicly available data sets. So is big data answer to everything? It is very helpful to have a very large sample size to explore sex and gender differences. But what we need to realize is that lots of these publicly available data sets are large in scope, so they have very large sample sizes, but they're, let's say, narrow in details sometimes. So the scope might be narrow, the sample size is large. So some of these data sets lack that deep understanding of sex and gender differences, like that context, let's say, to look for all relevant variables. So the sample size is large, and we're tempted to look at subgroup analysis. It is good to do a sex stratified analysis or sex and gender stratified analysis, let's say, in these large sample sizes, but we have to be aware that it's very easy. It's very simple to detect statistically significant associations in these large data sets. Simply, you have the power. But what you need to critically think about is that is what you find relevant, what is the clinical relevance, and what is the magnitude, and what is the meaning of this sex or gender difference that you find in these large data sets. Don't forget that for any subgroup analysis, including sex and gender stratified analysis, you should have sound motivation, and you should be conservative when you're interpreting your results. So you have to be aware of what you're doing and why you're doing it. So what are the considerations? We do lots of tests and interaction tests, meaning that we look for differences between different subcategories in the large data sets. So be aware of the number of tests you're doing. Pre-specify your hypothesis. Pre-specify your subgroup analysis. Think beforehand, what is the association you would expect? What are the differences you would expect? And try to think about the direction and the magnitude of that association that you expect to find, based on your knowledge of what you are studying. If you have surprise subgroup findings, be cautious about the interpretation. Present them as such, and be very transparent. Whether you had a pre-specified hypothesis in doing so, or was it a post-hoc analysis just simply because the data was available. So subgroup analyses are meant to form the basis for further studies. They might not be suitable for instant translation to clinic or policy or guideline documents, but they might provide the means for the others to go on with your results. So be cautious about instant versus long-term implications of what you find. That brings me to the discussion on accuracy. Large data sets. So think about what you're interested to obtain from your results. Normally, in our studies, what we are interested to get is a measure of effect, an association between an exposure and an outcome, X and Y. But what is desired is accuracy. We want what we find, so we want our results to be accurate, the effect estimates to be accurate. What is accuracy? It's a general term. It marks the absence of error. So what is error? Error is lack of perfection in your data, lack of mistake. It can happen anywhere during your research design, in your subject selection, recruitment of subjects, in your data, the way you collect your data, the design you choose for your study, in analysis, even at the stage of publication or interpretation. So it can happen throughout your research design. There are two broad types of error, random error and systematic error. And a lot of us know systematic error as bias. What is a random error? Random error means variability. That's your sampling variability. This means in any analysis that you do or any measurement that you do, some of your measurements or some of your measures of effect are above the true value and some of them are below the true value. Systematic errors or bias is when all of your measurements go in one direction. So it's not correct, it is an error, but they are shifted to one side. It's either above or below the mean. So now let's look at this figure. Random error means your measurements or estimates you get from your study can be anywhere. Systematic error means that they're still not true. There is an error involved, but they're all into one direction. So if there is a true measure, random error looks like this, and systematic error looks like this. It can also look like this. So now linking it to the topic of big data that we just had. If we have an infinitely large data set available, do we reduce the chance of error? What do you think? The answer is we do reduce the chance of random error. So random error would be reduced to 0 if you have a study that's infinitely large. Some of your measurements are above the mean, some are below the mean. They cancel out each other if you have an infinitely large sample. So when you're dealing with big data, you might reduce the random error. But systematic error is something that's not affected by increasing the sample size of your study. So you need to think about it carefully. Systematic error will remain in your data. If your data is biased, it will remain biased, no matter how large your sample size is. It looks like this. By increasing your sample size, you decrease the chance of random error, but systematic error, the chance of systematic error remains constant. Think about how sex and gender-related characteristics might be relevant for the error in your data. Think about the random error that is introduced by measurement techniques or reference values and cutoffs in your data. And think about how biological variance, so differences between the sexes, or how gender-related characteristics can affect your error in your data. Down the road, you want your results to be valid. You might have heard of internal and external validity with regard to your studies. Internal validity is your study validity. Your results need to be valid. What you find in your own data set should be valid. External validity refers to generalizability of your findings. If I am going to repeat your experiment, will I find the same results? Will your results be generalizable in my setting? That's external validity. So you want your own study. So let's start with our own study. We want our study to be valid. What threatens the validity of our study? The internal validity of our study is threatened by biases. I told you that bias is a sort of systematic error. You should be aware of all sorts of biases that might happen throughout your data collection and that can affect the results and interpretations and validity of your study, of course. So now, let's look at different types of biases. There are three different types of biases: selection, information, and confounding, and I'll come back to that. What we need to know about the bias is that your estimates might differ from the true estimates, but in contrast to random error, in systematic error or bias, your estimates always move in one direction. So if you look at this figure, you might introduce positive bias or negative bias into your data, meaning that your observed estimates might be different from true estimates, but in any direction. So it's not always overestimation, it can also be underestimation. It's not always towards the null, it can also be away from the null. So both can be the results of bias, over and underestimation. So now let's go to types of biases. You've heard a lot probably about selection bias and information bias. So what are they? And how sex and gender can affect your studies with regard to selection bias and information bias. Selection bias is a type of bias. It's a systematic error. It's a distortion of your results from the true, let's say, results or estimates that you're interested in. And they result from the processes that you choose to select subjects into your study population. So it can arise from those processes, the way you define. It can result from your protocol, but it can also result from the study participants themselves. They might or might not want to join your study. Why is it problematic? Because your study population does not represent the target population that you're interested in. Information bias is another type of bias that there is, again, distortion in the results of the study that you find. It deviates from the true, let's say, estimates. And it's the result of inaccuracy in the measurements of subject characteristics or in the way that you classify them. Those of you that are doing epidemiological and clinical studies know that it can be differential or non-differential, but we will not go into detail in that. There is yet a third sort of bias that probably you all have heard about it, and that's confounding bias. Confounding is the third sort of bias. And it happens when there's a third variable in your data that gives rise to the association under study that you're finding. So it distorts the interpretation of your findings because you fail to take into account the effect of yet another variable in your data that's affecting your results. We'll go more into detail about confounding and its comparison with effect modification in the fourth lecture of this series. So now let's start with selection bias. It's a systematic error, and it can result from procedures, or it can result from factors that influence the study population or participation of subjects in your study. So why can it be problematic? Why is selection bias problematic? It's because the relationship or the association you find between exposure and outcome in your study is different for those people, those subjects, individuals that participate in your study than those that do not participate in your study. And that can introduce problems. So selection bias happens when systematically the process that you have for selection of subjects into your study, it's in favor of selecting a specific group, or it overlooks selection of another certain group of individuals. There are many different types of selection bias in the literature. Here, I just mentioned a couple of ones that you hear most about in epidemiological and clinical studies, and I will try to link it to gender and sex-specific characteristics to see how it might affect the gender and sex-specific characteristics might affect selection bias. So let's start with self-selection. It's a form of selection bias that the reasons for self-referral might be associated with the outcome under study. So let's have an example. You're interested, your study goes over a screening test for detecting colorectal cancer. What are the different scenarios that can happen that might lead to selection bias in your study? First scenario is that people that volunteer to participate in your study for cancer screening for colorectal cancer, they're generally more health cautious than those who do not participate in your study. What does it mean? It means that they might have a lower risk for colorectal cancer. Can you think of how gender can affect participation of people in your study? How gender-related characteristics can interfere with who will and who will not participate in your study? Think about, for example, women being more health cautious than men and participate in your study. How can it affect your results? You need to think about it. Scenario 2. In the same study, you might encounter another scenario. When people who volunteer for cancer screening in your study, they do it because they're at increased risk for colorectal cancer. They know they have a positive family history. So in contrast to the previous scenario, now you're dealing with a group that has a higher risk of your outcome. Now, think about how gender-related characteristics can affect your study, or sex-related, let's say. Think about if colorectal cancer is a cancer that is more common in men. Men are more aware of that. It can affect, especially the rectal cancer, it might affect men more. Then think about the scenarios where men are more likely to participate in your study because they think they're at higher risk. So in two different scenarios, the gender-related characteristics, attitudes, and norms can affect your study in different ways. Now, let's move on to another form of selection bias, selective non-response. That's similar also to the previous example of self-referral somehow. It happens if the decision to participate, to respond to participation in your study, is associated with characteristics of participants that are correlated also with the risk factors that you're studying for your outcome. What is the example? Imagine that you're studying the effect of the association, let's say, between smoking and heart attack. Smokers who have symptoms of the disease and they know that they're at higher risk of the outcome, maybe they don't respond to participation. Or maybe they respond because they know that they're at higher risk. So it becomes problematic and leads to selection bias when this response to follow-up is differential. So in this case, you can get biased estimates of disease incidence, prevalence, and exposure outcome associations. Now, think about the role of gendered attitudes, behaviors, and norms. You're dealing with smoking. It's a variable, it's a factor that can also be culturally perceived differently. In some cultures, it might not be very socially accepted for women to be heavy smokers. Think about how that can affect participation of men or women in your study. So these are the examples how sex and gender-related factors can affect participation in your study and can interfere with selection bias in your study. Another form of selection bias is loss to follow-up. Loss to follow-up happens if the dropout rates for exposed and non-exposed, so people with or without risk factors in your population, are different. In other words, we say if exposure really affects loss to follow-up. It becomes problematic because subjects that drop out of your study during follow-up are different from those who do not drop out. Now, think about the role of gender here. How gender-related characteristics, norms, behaviors, attitudes that are also culturally related can affect loss to follow-up in your study. Think also how sex-related characteristics can affect that. What determines that a man or a woman comes back for your study, stays in the follow-up for your study, or they drop out of your study? Now, let's have an example. You are doing a study on patients that receive treatment for a specific cancer. What are the reasons that people might or might not come back for follow-up? They drop out or they stay in your study. People may not return for follow-up because they become asymptomatic. They don't feel the need anymore to come back for your study or to see the surgeon. It might also happen because they have a very bad outcome. The treatment didn't work for them. They have worse pain, or they're not functioning properly anymore, or they experience a lot of complications, or they die. Now think about, in these two different scenarios, think about the role of gender-related characteristics. Think about how women and men might differently react to this. Think about the first scenario, for example, when they become asymptomatic and they might not want to come back. Is it more common among men or women? What do you think? The second scenario. Are men more likely to drop out, or are women more likely to drop out? So sex and gender-related characteristics can affect the decision whether or not men or women participate in your study, and whether or not men or women decide to stay in your study. So it's good to be aware of all of these characteristics when you're designing your study and when you are actually considering types of biases that might occur in your data. Selection bias, as I said, and among those types of selection bias, loss to follow-up can be problematic because you might have a different prognosis for the people that stay in your study compared to people that drop out of your study or do not continue. Now, the final part of this lecture goes over information bias. What is information bias? Information bias is also a systematic error. It's a distortion. That the results that you get are different from what the true estimates are. And it results from the inaccuracies in the measurements that you do during your study of subject characteristics, for example, or it happens because of incorrect classification. When can information bias happen? Anytime during your study. And it can affect both your exposure, so your main exposure, the risk factors you have under study, your main outcome, the disease that you're studying, or other relevant variables. So all the characteristics and variables in your study are subject to information bias. And as I said, it can result from the measurement. Think about you're measuring blood pressure, for example, for your study. There can be some degrees of error in your measurement. So information bias can result from the way you measure the blood pressure, or it can result from the way you classify them. For example, hypertension versus normotension. Now, here I've listed for you the possible sources of measurement classification error and of information bias, saying being measurement error or classification error. And I want you to think with me over the role of sex and gender here. What is the measurement error? Measurement error is any sort of imperfection that happens during the process that you're collecting your data. It can happen from the instrument that you're using for your measurements. Think about the cuff you're using for blood pressure, the measurement. It can result from laboratory assays that you're using for gathering, for measurement of certain biomarkers, for example. Medical records that you're using for gathering information about study participants' interview processes. Now, think about role of sex and gender in any type of any of these types, different sources, let's say, of information. Think about whether, for example, the instrument that you're using or laboratory assays that you're using will be affected by sex-related variables. Think about whether you should have different instruments or the laboratory assays should be sex-specific. If you're reviewing medical records to gather information about your participants, think about gender-related characteristics that might affect it. We had the example about coronary heart disease and that symptoms might be different in men and women. So think about it when you are going over the medical records. Will one size fit all? Should you treat men and women the same when you're gathering information about men and women in their medical records? Think about the interview process that you're gathering information. Should you treat men and women the same? The same questions? Should you ask the same questions from men and women in the same way? Failure to take into account sex and gender differences in any process that you use for gathering information during your study might affect your study and might introduce information bias into your study. Information bias can also be a result of a classification error. Here, think about the choice of cutoffs that you use for categorizing men and women in your study. Should you use the same cutoffs for men and women? Should you categorize them the same? Or do you have information from the guidelines or information from previous studies that the same cutoffs might not apply for both men and women? These are all the aspects that you should have in your mind, you should take into account when you are gathering information in your study. And last, to conclude this lecture, how do you control for selection and information bias with a sex and gender-informed perspective? We'll get back to that in the fourth series of this lecture.
So, Maryam, you didn't make it easy today. It's quite difficult to make a good choice, for instance, of your population and how to attract your people into for instance, your clinical research. Lieza, if you look at your field, where to start if you hear the lecture of Lieza? I think it's really a puzzle.
No, it is. It is a big puzzle and it can be very difficult. But we just have to start and continue from there. So, for instance, based on the lecture from Maryam, I was thinking of one current study of mine. I'm investigating neuropsychological complaints in patients with dementia. So, for instance, aggression or depression. And that's usually based on a questionnaire from an informant. So somebody else informs us about the patient. And we know some differences exist in Alzheimer's disease, and I wanted to see if there were similar differences in vascular cognitive impairment. And then when I saw the data, I realized that in males, more often a spouse was the informant, while in females, it could be somebody else, like the neighbor, or maybe a daughter who doesn't live at home. So there's a different, they don't know if there's nighttime disturbances because they never spent the night there. And I found some differences, and I wanted to write the discussion thinking like, well, this is a problem. There's information bias.
And a lot of disparities also.
Definitely. But I think when we make a next step to the clinical practice, this is clinical practice. You don't always have the information from the spouse. It could be the daughter or it could be the neighbor. So although I need to acknowledge this information bias, I also think it's representative of clinical practice.
So you have to take the bias into account of your research.
Sometimes I think that's also important to do.
Yes. But do you try to mitigate it in a way?
Well, I try to make the distinction in the research and explain that there is this information bias. And on the other hand, that if we think about implications, clinical care, we have to acknowledge this information bias, and there is no other way around it.
Yeah, there is no alternative.
There is no alternative.
Yeah.
Yeah.
Yeah. Do you have the same experience in your clinical research?
About information bias?
Yes.
Well, what I think is very interesting about information bias is that I sometimes really miss information, and I suspect that there's information bias. And for example, if you look at the large randomized clinical trials in cardiovascular field, then very often it's not clear, because we know that for many domains within cardiovascular disease, there is a difference between the percentage of women who join a clinical trial and those who are there, the prevalence in the real world. So we know we are missing women in the clinical trials, but we don't know where we miss them. Is that because they're not asked to join the trial, or is that because if they read the patient information that they decide to decline?
And we know that women read more often those type of information than men, isn't it?
Yeah, we know that women more often read the labels which have to do with medication side effects than men. And if you read patient information, because it has to be complete, and then you read all the risks. So you can, imagine that might also be a reason why women are not joining trials. Then it can also be of logistic reasons, because very often you have more study visits. And you don't also, because I think it's striking that, of course, there's always, with those large trials, there's loss of follow-up. But never there's the ratio between male or female loss to follow-up is provided. And very recently, there's a landmark trial published in the New England Journal of Medicine, the Lodoco study, which investigated the effect of colchicine, which is a drug, immunomodulating drug, formerly used in rheumatic diseases, for instance, and now used as a cardiovascular drug. And this study is partly done in the Netherlands, so it's also our proud. But when I read it, it was only 10% of the population that was included were women. So then I think, like, it's not only...
What are the conclusions then?
Yeah, but also where were the women lost? And I asked one of the primary investigators, where are the women?
Yeah.
What happened? And he said, well, they more often declined. And I think also there is information bias, because you actually want to know, like, what is happening at what stage.
But is it then necessary if you want to compare things, that we ask women or men in another way to attract them or to get them into a study?
Yeah, exactly. I think that can be one of the ways. Getting back to what you just mentioned, I think what Lieza mentioned was very important. That's real life. That's what you have in practice. So lots of the time you deal with data that is already there, and that's how practice is built. There are GP databases, cardiology databases that you see clear indications that there is selection bias or information bias, but you have to live with it. Sometimes it's good, just to be aware that it is out there. Try to quantify it if possible. Try to report it and acknowledge it when you're reporting the results, that you know that it might be out there, and give also maybe suggestions to, like the next studies, how to prevent it.
Did you do that?
How do you mean?
In your study, to be so explicit if it comes to gender or to sex?
I try to, in the discussion, I try to make it explicit, but it's difficult to capture everything, because there's more limitations to a study than only this sex and gender information bias.
And you might jeopardize the risk of your publication of your study, because journals, if they think your study is biased, they're not interested to publish it, of course.
But is that, if we want to integrate sex and gender into the research, and if we notice this bias, sometimes information or other bias, is it then attractive enough to incorporate gender and sex? Because a lot of people will say, no, we don't do that.
Well, I think in general, it's just quite difficult. You know, we have to acknowledge it is quite difficult. And there is not a lot of information, like Jeanine is saying, like we often don't know why we have a higher loss to follow up in females. So I think there's more research needed for the reasons.
So we have to take that hurdle.
We have to take that hurdle. If we have more information on why we are losing them or why they don't want to participate, then we can, as you suggest, maybe use different strategies even.
So the strategy is very important. Do you have an example that you attracted women into a study in a completely other way than men? Yeah, I think that might be the solution.
Yeah, well, I mean, if I want to attract women, I do studies in the field of women who had hypertensive disorder of pregnancy. And then I asked them if they want to join the study to know more about why did they have a hypertensive disorder of pregnancy, and also about the long-term effects. And then I also mentioned that it's very important for their daughters, for example.
Okay.
So that's also a incentive for women to join a study. And most of the times they're very willing to do that. But I also think that talking about strategies to attract more women, you also have to be more creative and to see, like, first to define what are the obstacles. And if the obstacles are, for example, logistic reasons, I know of hospitals who offer transport. So and that will help to make the barrier for joining a study lower.
If you, for instance, want to attract people of lower class with transport problems, etc.
But I think when I can add to that, it's also about when is the study conducted. So if you have to bring your mother, for instance, for a study, might be more convenient to do that on a Saturday morning than if you have to take off of work to take your mother to participate in a study, for instance. So it's also really, I think, when you're including patients, ask about what is the problem so you can adopt your strategy even along the way.
Creativity is then very necessary.
You need creativity. And I think that's very an interesting field in study design, is also maybe to do a pilot, to see, like, if you would do such a study, and just to ask, like, a couple of patients, like, if you read this information leaflet, are you interested to join the study? Yes or no, and what are the reasons? And that will be, like, people of your target population, of course. And then to see, like, what are their ideas, and also to involve patients themselves. And I think that's an area that we really can improve in as researchers, to really more involve the patients and target population.
That's what's happening now a lot, the patient participation at the level that you're writing the protocol, even when you're writing your grant, for example, to apply for funding for a specific research. And in each case, like in all steps of the study design, in your protocols, you should validate your protocols, your questionnaires first. And then you should validate them both in men and women. You should have a representative sample asking them. And
so then as a pilot is very handy.
Yes. So asking them what is their interpretation of this question, or maybe the interpretation of a man and a woman is different from the same question, and then you realize something is wrong. I need to change it.
And then you have to ask it in another way.
So exactly. And then you need to do it throughout the whole process, and really before starting including people. So you should have a very well thought
before you even
advance,
apply for your grant.
Exactly. But I think giving information really helps. Like the case that you said, you try to motivate people by telling them this might be relevant for your daughter as well. Breast cancer screening worked. The mortality risk attributable to breast cancer. So the mortality rate in Europe for women is now 3% because of breast cancer. So it's way down that what it used to be decades ago. So screening for breast cancer works. It should work for cardiovascular disease as well. Just giving the right information. Campaigns, giving information really helps. We have successful examples. We have successful scenarios, especially in the Netherlands, that is some screening programs are really working. So we have to do it for the rest.
Yeah, and it helps to diminish the bias.
Yeah, and maybe also because we're we're focusing on women, but maybe it's also good to mention that there are some areas of research that women are overrepresented, and that men are the group that are understudied. For example, in osteoporosis research, it's very often because it's more common in postmenopausal women that the studies really only target postmenopausal women. And then men are excluded. But also men can have osteoporosis.
And that is, I think, necessary
to
also in a follow-up.
study. Yeah, exactly. And to study enough men before we know for sure that the study drugs are effective and also safe in men.
Yeah, so there's still a lot to do.
A lot to do. In your follow-up studies, if you want to get a simple, very first indication of the bias, if you have the baseline data available, you can dig into that. The first thing to look at is, if I look at the baseline, is characteristics of the population that falls out of my study the same as those that stay in? And simply look at the gender balance there. So it's just the first start that gives you the first impression of who are the people that are dropping out of my study. So examining your baseline data in detail is very, very important. You might not have detailed information during follow-up, but if the trial is, well designed, you should have detailed information at baseline. So that gives you lots of clue and information about the participants that stay in your study or drop out of your study. Yeah. That can be the starting point. Also then to avoid it for future studies.
And it's more than just men and women. We also have to look like which kind of people are that? Are that elderly? Are that people of certain ethnicity?
Exactly. So
age,
characteristics,
socioeconomic status,
etc. Yeah. We have to take a lot into account to do very well research. We will take a break now.